Welcome to the ED Clinics podcast. My name is James Woolidge and I'll be your host for this series where we'll be discussing everything to do with shockwave therapy and men's health conditions. That's everything from erectile dysfunction through to chronic pelvic pain syndrome, Peyronie's disease, hard flaccid syndrome, amongst others. We'll be talking to a host of experts from around the world to shed some light on these complex conditions. And we'll also be talking to patients that have been through treatment journeys themselves so you can get a greater understanding of how we can help a broad range of people with these conditions. So, without further ado, enjoy this episode.
Thanks for joining us again, Eve. The subject today we're talking about is our approach to treating chronic pelvic pain syndrome. And on the podcast before, we had your patient kindly give us his journey that he's been on with you, and that he's doing really well. How is he doing now? Because this is now a month or two since we spoke to him.
Yeah, so still, still maintaining, really good ability to function, no pain, so he hasn't had a relapse or anything. But it's still, he still has to do a lot of self-management side of things as well with regards to the sort of dietary issues and things like that. So he's still very much looking after himself as well, to try and avoid any kind of trigger that may then, create this relapse again. Okay,
well, that's good news. So on that note, and with him being a particularly good example of that, of the sort of whole approach, I don't like necessarily the word holistic, but our holistic approach to the management of these situations. Can you just talk us through, the approach we take at ED Clinics in terms of, case history taking and what our approach is for CPPS?
Yeah. So I think this is really, really important, because in order to manage these, men with those types of conditions well, it is really, really important that we understand, everything, because we got the physical nature of things, but we also got, the mental health side of things as well, because those men can get really, really depressed. So it's a question for us to kind of deal with that in as much as we can. But also we have to understand that we have limitations as well. And this is where often we collaborate with psychologists, basically to try and give patients a sort of more overall care management, package as such, in such that, we can deal with an awful lot of the physical side of things, and to a degree we can coach them and support them. But when a deeper seated rooting things, is far better that, psychologists are involved as well. So really from my perspective, which is not really that dissimilar to, if I were to take an MSK history. So really, I think it's starting off with letting the patient kind of summarize, what their problem is. I think often, patients want to talk, but I think we got to be careful that we don't block their talking too much, and really let them, get it off their chest what they have to say. Unfortunately, sometimes medical professionals, so they don't necessarily get the opportunity to, kind of say what they want to say, because often within the NHS there are time limitations. I think this is again where we are.
How sorry to interrupt. How long do you give for that initial consultation? Because I often get remarks back saying, it's nice to be able to have this time to go through everything. How much is your consultation time at the start?
It's anything from an hour to an hour and a half.
Right. Yeah. And that seems like a long time in NHS world, doesn't it? It seems like completely impossible in NHS world. But in private world, it's surprising how often you take up all that time, isn't it, in that first consultation?
Absolutely, because there's so much anxiety associated with the whole condition. Because don't forget, by the time we see these men, most of the time they've been through a whole remit of investigations, and they might have seen a urologist. Obviously, they will have seen their GP multiple times. They may have gone through gastro. They would have gone through loads of different types of investigations. And again, the difficulty often with these men is that, I mean, it's a good thing, but most of the time, all those tests tend to be negative. So, so not really being able to have any kind of positive test makes it actually a lot harder to deal with, because obviously these men have got a real problem. They have real symptoms, but they've got nothing to show for it, which, doesn't really help with the whole anxiety side of things as well, and often, they then become poorly understood, partly, perhaps by partners, but also their work environment and all of that. It's not something that we know a lot about. With chronic low back pain, for instance, I mean, the workplace knows a lot more about chronic back pain and providing a good chair or a sit to stand desk. All of those things are really well integrated within our MSK field. But when it comes to urology, it's all a little bit like, well, never heard of this problem before, you must be making it up, So I tend to, obviously, as I say, get that initial sort of assessment going. We're just saying, can you just, summarize to me what your problems are, who you've been to see, what's been done to date. Then I detail very much all of their symptoms, from pain symptoms to mapping out, where do they have pain, because sometimes it's not just a pelvic region. They can have back pain, abdominal pain, sometimes referred pain into the legs. So it's trying to work out again, well, from a whole MSK perspective, how much is involved. So we map the whole pain area out. We then look at any other types of symptoms to do with the with all the kind of waterworks, let's say, have they got frequency, anything that is out of the ordinary. Sometimes, they may have issues with ejaculation, from painful ejaculations to dry ejaculation. So all of those kind of things need to be talked about. And obviously these are, sort of subjects that most men don't really want to go into too deeply. But I think it's important from our perspective that we guide that, and that we use the vocabulary which is needed to be used, so we get really good understanding of what their symptoms are, but also that it's okay to use all of those words, because that's fine. We create this environment where it's perfectly okay to talk about an erection or an ejaculation or anything like that.
And I think on that note as well, you talked about the area of pain that gets mapped out, but I think a lot of the time, depending on whether they're in that younger group that have some maybe associated issues with erectile dysfunction or hard flaccid syndrome, or in the older group even, where they have, which is, we touched upon it should be the case, particularly with the older patient, that they do get screened out, obviously, for prostate disease, prostate cancer, so forth. And some of them, they do get treated with antibiotics for classic prostatitis. And then the legacy of that is that all the inflammation dies away, their PSA levels die back, but they're left with the pain is still the same. And then they're told by the urologist that, the problem's gone away. It's the pain is not my issue. Keeping you alive is my issue, or making sure you haven't got prostate cancer. These poor chaps are, and what they often come in with is no one's really ever listened to them about the fact that pain often then spreads into the testicles, into the penis, and with that younger group, giving them sort of changes to the feel of their penis and all these other things, which, going back again to how you said about that time we give them, they're suddenly being able to express all of that and feeling so relieved that they can. Because they often say, well, I knew where my prostate was, I knew where my pelvic floor was, but why have I got pain in my testicles, in my penis? Even the tip of the penis hurts, and there's nowhere near my pelvis. And suddenly they're into that conversation and that ability to talk to us about it, which they often feel, very therapeutic about, don't they?
But absolutely, but there can also be a little bit of confusion, especially if they've sort of been searching the internet quite a lot, because we talk about chronic pelvic pain syndrome, we talk about hard flaccid syndrome, pudendal neuralgia, which is sort of an entrapment neuropathy of the pudendal nerve. Now, the main problem with a lot of those, or even just prostatitis, is that all of these conditions can have very, very similar symptoms. And their presentation is not actually that hugely dissimilar. So it can be quite confusing for a lot of men once they start to kind of research everything. in that they say, well, I think I do think I've got pudendal neuralgia as well, and I've got hard flaccid as well. Well, you probably haven't got all of it, but there are similarities, and this is the big problem, I think, is that this is still a condition that we don't know an awful lot about. You look at the research of hard flaccid, and there's not a lot of clinical trials, or a lot of mention in the research. So these are all still a lot of areas that we need to gain more knowledge, and perhaps finding ways of being able to be clearer on diagnostics in order to, not necessarily categorize people, but being able to strategize better in how we manage these types of conditions.
Yeah. Okay. So we talked about the case history taking there. So for the chaps out there that might see us for this condition, then moving from that into the examination, I know that some men would get particularly anxious about intimate area examinations. And I know, for one, there's a few of us in the group that use sonography. So we use ultrasound scanning of, for instance, the bladder if they're having, micturition, which is multiple, or polyuria, multiple efforts of going to the toilet because of tension in the pelvic floor. But generally speaking, let's say for the chap that we just listened to, what kind of process of examination would you go through with him?
So I start, again, being an MSK physio, very much doing an MSK assessment. So I look at their lower back motions. I look at their hip motions. I look at muscle length. So the big muscle groups that attach to the pelvis. Yeah. So I kind of work my way from outwards inwards. Yeah. So looking at any kind of anomalies of the sacroiliac joint, symphysis pubis, anything to do with that side of things. Yeah. There's then also a couple of tests that we can actually do with regards to testing the pelvic floor in itself, in such that, there's like with any kind of muscle groups, we have slow and fast twitch fibers. So, how quickly are they able to recruit that muscle group, but then also how long are they capable of sustaining that? So those are two simple tests that we tend to do in order to be able to identify, well, is there a dysfunction of this pelvic floor or not? We also run, some specific questionnaires alongside of it as well, obviously dependent on, whether there's erectile dysfunction or not. So we may throw a couple of questionnaires in there as well to get an understanding of that side of things. Now, there's also an internal examination that can be done as well. So this is through the anal sphincter. But obviously, again, the way that I tend to look at it is that it's not something that, first of all, I would do with everybody. Second, it's something that obviously the patient needs to consent about and needs to understand why we do that. And most of the time, to be honest, I've done it more once I got to know the patient better and they got a better understanding of exactly what we are trying to actually achieve. And also then actually leads to a certain type of internal manipulation to help to release trigger points and things like that. So, so it's something that, I don't tend to do first of all, it's something that I've to date have always sort of introduced at a later date.
And how do you, obviously a lot of people come to see us because of the ED Clinic's website and us talking about the Shockwave aspect of that. So how does then that progress into getting the patient to understand what you're going to be doing treatment wise for them in the room? We've talked about you might do some intraanal work, which is less common than the Shockwave, which is sort of a standard treatment approach and everything we build around that. Just talk us through how we do that.
Yes, so it's really just a question of working out, well, what have we got in front of us? What are our main symptoms? And that's how I normally tend to base myself on, in such that if there is, if pain is the majority of the symptoms, but actually we haven't got too many issues with any kind of the erectile function side of it, then obviously the whole treatment becomes more pain reducing. So in that sense, our shockwave therapy, as we know, is a very good modality to help to reduce pain. But again, the the settings and the tolerance side of it, I would be a little bit cautious with, in such that what you wouldn't want to do is flare patients up. So so that would be partly treating the shaft of the penis and the perineal area. Yeah. And you know, where normally in erectile dysfunction we tend to just use treat the crura. Yeah, I actually treat the whole of the perineal area, also trying to actually get to deeper seated areas. And what's quite interesting is that sometimes, you know, I've had a couple of patients who have a little bit of you know, referred pain in the medial side of the thigh, yeah, which almost could look a little bit like a sort of pudendal entrapment. Yeah. And basically what you can sometimes do with the shockwave is to reproduce those symptoms. And again, from a therapist,
I mean,
from a therapist perspective, it's amazing to do that, because people go, yes, that's it, that's my pain.
I use it, I was just about to say, as a diagnostic tool almost at the start. We know how focused shockwave is really good for that. And, you know, in those patients where they've had referred pain up through into the penis, and in fact, this one chap had it actually just on the tip of the penis and nothing between there and the pelvic floor. And I must admit that was quite unusual as a referred pain. But there was a particular part, and I'd done some manual palpatory work, seeing if I could feel anything through the pelvic floor and so forth, but nothing. And then with the depth that the penetration gives you with the focus, I managed to hit a bit, you know, high up between his crura, and it just completely reproduced his symptoms. And then we went into treatment and then got rid of his symptoms. So it got rid of that referred pain, which I think is the real skill of focus shockwave in particular, getting those bits you can't get to necessarily with your fingers. And I would say that to a couple of patients, that I think there is an option. I think that patients that might be fearful of doing the PR, the intraanal work, that we can use perhaps sometimes focus shockwave to not have to do that, because we can get deep almost with the shockwave as we can with a digit, trying to search for those areas within the pelvic floor.
And that's the nice thing, to have those options, isn't it? That if you feel that things are going well with the shockwave, then there's no need to do the internal stuff. So it's patient choice as well, you know. So it does allow us to just have a couple of extra tools. And we know that obviously with our shockwave, we can get up to, you know, sort of 12 centimeters. So there's no doubt that we can affect those pelvic floor muscles.
And then in between those moments of the treatment time in the room, you've obviously, as your patient was describing on the previous podcast, we're giving them support in terms of not only perhaps working on the endurance strength of their pelvic floor, but quite a lot in these cases trying to relax their pelvic floor, because they often become too tight in a way. And I think that sometimes trying to explain to patients how, look, you know, we can look at the pelvic floor like any muscle that's got itself in a particularly tight, dysfunctional situation, where these things, like I explain trigger points to patients and things like that, to try and get them to understand that they're just referred pains traveling everywhere that you might get from your back or your shoulder or whatever else, and make it as simple as I can, you know, because my brain's pretty simple. But so, you know, that sort of stuff we also give, don't we, as well, in terms of their pelvic floor rehab.
That's right. So, you know, simple self-management strategies, as, you know, deep abdominal breathing exercises in different positions. So the way that I kind of structure it is that, so again, normally for my kind of ED patients, I tend to take half an hour treatment, which I'm perfectly happy to be able to do a treatment in that time and not having to rush things. For the CPPS patients, I tend to take 45 minutes, sometimes an hour, purely because I want to educate them on certain things to do. So, you know, teaching them the deep abdominal breathing exercises in different positions. You know, also moving on to doing sort of reverse Kegels. They've often heard of Kegels, you know, and really tightening things up. But actually, it's just trying to get them to understand is that actually we need to do the opposite. It's about relaxing that. I then tend to also, from the work that Jo Milios has done, you know, I tend to use some of her yoga poses, to help some of the stretches, you know, just to try and influence those bigger muscle groups. identify certain trigger points, either in the abdomen or in the adductors, which again, they do a lot of self-treatment and self-trigger pointing. Yeah.
Right. Okay.
Because, the advantage often is when patients feel those things is that, if you feel a trigger point, as a person that it's painful. We only listen to the patient and get them to tell us, oh yeah, that hurts, or it doesn't hurt. But obviously from a patient perspective, it is quite strong that you can try and do this treatment themselves. Yeah. So each thing is kind of built up a little bit, that each time when they come in, it's not just about the shockwave, but we just teach them all these other bits, as we go along, on what they can do. Other things obviously to consider is to work out what the triggers are as well. So like for instance, in Kevin's case, it was hugely dietary related. So he did very, very well in trying to be very, very specific about understanding what specifically triggered any of his flare-ups. But he was quite interesting from a point of view as well, that once he started to do the deep breathing exercises, like he would go to the toilet and then be like in agony for 20 minutes. But he knew that he could get himself into a position, and that 20 minutes reduced to like 4 or 5 minutes.
Right.
Now that was hugely powerful because he hadn't had anything. He was just riding it out before, where suddenly he became more empowered, that he goes, okay, well, if I do this, that's the result that I get in return for it. And basically what the whole of the sort of sensory side of it and the whole, pain system started to calm down purely because you had means of getting on top of it. When I first saw him, the pain was in control of him. He was not in control. And that's what, he was a completely different person by the time we'd finished, purely because he gained control over his life.
Yeah, he was pretty good at getting that across, actually, that aspect of control, wasn't he? Pretty impressive stuff. And then, what we're trying to achieve, obviously, as ED clinics is that, how many clinics are there now within the group?
I think we got 14.
So we're trying to, as patients that are listening to this, perhaps thinking about where they're going to go around the country, what we are trying to do is make sure that the story they're hearing from us now is replicated amongst all the clinics, and they should have the confidence of knowing that the approach is pretty similar, if not exactly the same as what we've been discussing. That's our hope, is that we can create this evidence-based, sort of data-driven approach to these conditions across the board, so that everywhere they go, they hopefully get the same as what we're talking about.
And I think that this is quite good, because most of us, I wouldn't say most of us, but all of us are quite driven by making sure that we're all clinicians that want to work holistically. So I don't think it sits well with anybody to just kind of, let's call it point and shoot. I think as therapists, we all want more. We all want to treat a person rather than a condition. And for that reason, I think, all of us have been doing extra training in order to get much better understanding of all the adjuncts, and the shockwave is only part of that.
And I think, as you'll testify, I'm sure, when we get together occasionally to have conferences and meetings and so forth, I think a part of that drive you just touched upon is that we all recognize that where we came from is musculoskeletal, back pain, whatever else we used to do. And now we're treating these mental health conditions. We all pretty much say the same. It's now become the most rewarding and interesting part of our daily life. It's probably why we're very keen to just say, look, it's fine. If you want an hour, we'll give you an hour, because actually helping these patients, a part of which I think is probably still because the NHS is struggling post-COVID to deal with these patients and give them an adequate amount of time. And just that time aspect, I can think of one patient I saw where he was a young chap, but I only saw him twice. And just the time, the description of why he was suffering, what he was suffering, a few simple home exercises and tactics, and I didn't actually even need to treat him with shockwave therapy. He was done, but it still took 2 hours over 2 sessions. But I'll probably remember him a long time. He came with his mum, bless him. It was lovely being able to get him back to a normal life. Pretty good. On that note, I think we're trying to keep these short and succinct, otherwise people will get bored of us waffling on. So thanks for that, Eve. And no doubt we'll come back again and talk about another topic at some point in men's health.
Yeah, absolutely.
Bye.
Yeah, bye.
Laters.
Cheers, mate. Bye-bye.